Move on quickly to our next session. The next session titled Surgical Nightmares Surviving the Unforeseeable. May I invite to chair the session Dr. Kiran, Dr. Captain Siddiq, and Dr. Jayachandran Babu. Dr. Kiran from Kottayam, Dr. Captain Siddiq from Tiruvalla, and Dr. Jayachandra Babu from Kottayam. And the speakers for the session also, may I request you to kindly take your seats on the dais. Dr. Shyam Krishnan, Dr. Dinesh Babu, Dr. Binto Matthew, and Dr. Muhammad Ismail, please. The first speaker, Dr. Shyam Krishnan. Yes, over to you, chairpersons, please.
Please start.
Okay.
Hi, hello everyone. Warm regards from Astamim's Kannur. Great conference so far. And without wasting much time, I'm going to talk about a few perplexing gallstone encounters that we've had. Now every surgeon could go on ranting about the whole plethora of complications pertaining to lap cholecystectomy. But this time I decided I'll just stick to retained, dropped or slipped gallstones, which occur due to inadvertent spillage of stones into the peritoneal cavity during surgery. Although the incidence of intraoperative spillage ranges from 0.1 to 20%, we surgeons should consider ourselves to be immensely lucky, because only 2.3 to 7% of these patients really present with complications. The early complications could be related to abscess formation, collections, or localized peritonitis, and the late complications are related to migration of these gallstones to distant areas. We even have case reports of gallstones as content in inguinal hernia sacs 10 years after cholecystectomy. Now the mode of presentation is also highly variable. On to the cases. The first case is regarding a 70-year-old male, a diabetic, hypertensive, post-CABG patient with COPD with respiratory failure. He had an attack of acute cholecystitis, underwent percutaneous cholecystostomy, and was taken up for lap cholecystectomy after 8 weeks. The surgery was rather uneventful, although the GB was inflamed. There were multiple omental adhesions. Now, after 1 week, during the post-op review, it was all is well for the patient and for the surgeon. And after 3 weeks, this happens. Now, you can see the gallstones extruding through the skin. This was the site of the percutaneous cholecystostomy drain, pigtail drain. Luckily, we could solve the problem with a bedside local exploration, and the following imaging showed no other collections. And on to case 2. This was a 42-year-old male, a known diabetic, status post PTCF or anterior wall MI. He had an attack of acute cholecystitis, but due to personal reasons, we had to manage him conservatively. Now, after 2 months, he came back to us and we went in for a lap chole. Unfortunately, we had to convert it to open. There were dense adhesions, the GB was contracted, there was a GB perforation. Although we came out well and the drain was kept. 1 week after discharge, he presented with pain at the surgical site. Obviously, it was a surgical site infection. Luckily for us, the LFT was normal. He was admitted and a CT was done. Now, these are the CT images. Now, on the left side image, you can see a collection around 4 cm in the GB fossa with a radiodense focus inside. And the right side image shows the adjacent mesenteric stranding and the collection extending to the laparotomy wound. So this is the CT report. Now we were lucky that he was a very compliant patient. As expected, we went in for wound exploration and drainage was done. And luckily we hadn't had any other problems after that. Now on to the third case. This was a 48-year-old male. He underwent an ERCP for choledocholithiasis, and he refused to turn up for elective lap cholecystectomy. Of course, he was unlucky. He had a recurrent attack after 4 months, and he had to undergo a second ERCP. And this time, he decided to turn up for surgery. As expected, the case was extremely difficult. But we were lucky, during the immediate post-op, he didn't have any complications. He went home happy. Now, after 7 months, this guy presents with fever and right-sided abdominal pain. We usually showed a collection. We told him that ordinary drainage would not suffice, but he was adamant that he didn't want a surgery again. And so we arranged for a pigtail drainage of the collection. Now, as expected, the drain got blocked and the symptoms persisted. And finally, we could bring him up to the operating table. The CT showed an irregular, thick-walled, enhancing intraperitoneal collection posterior to the right lobe of the liver, superiorly abutting the right hemidiaphragm with a radiodense focus measuring 8.6 mm. These are the CT images. I hope you can delineate the collection there, posterior to the right lobe. And the image on the right side, with difficulty, I hope you can see the radiodense focus inside. The abscess was drained laparoscopically and the retained stone was retrieved. Luckily, the patient recovered well and there weren't any problems thereafter. Now, this is a short surgical video of this case. You can notice the thick-walled abscess posterior to the right lobe, and you can see the pigtail drain, blocked pigtail drain coming into view. Now here the calculus has been retrieved. And the cavity has been cleared of debris. Thorough lavage has been given. So, the conclusion we arrive is that no cutting corners is advised while explaining complications in lap cholecystectomy, especially in cases of GB perforation. As was noted in a WhatsApp forward a few days back, first you have to see the patient medico-legally and then medically. So, if possible, document everything. And once the perforation has occurred or you have had spillage of bile, always attempt diligently for stone retrieval if and when you notice a spillage. And off the record, I very much believe that this session of surgical nightmares is not intended to dent the confidence or to discourage the upcoming surgeons, but it is just an opportunity for you people to learn from our faults or our experiences. Thank you very much.
Thank you, Dr. Shyam, for wonderful presentation. In the second case, actually, why don't you try a laparoscopic drainage of the abscess?
No, actually, the patient had features of a deep surgical site infection. So, and he had developed enough wound-related complications also. So we thought that going in laparoscopically with this field would have been rather difficult. And so we opted directly to go in by exploration and a real laparotomy.
Any other questions from audience?
Good afternoon. This spillage of stone is
Yes.
a common thing when we start doing this procedure. In the early phase of our experience, we may come across it.
Very much.
Most of the time we try to take it out, or bigger stones can be retrieved easily because they can be grasped. But the small powdered sort of sludge
Definitely.
cannot be taken out. In that case, we give a thorough lavage and keep it drained, and if possible, try a little bit of negative suction. But most of the time, this stone get trapped between the omentum or stomach,
Yes, sir.
or go below the go to the posterior aspect of the stone where we cannot take it back. But I have few instances of this spillage of stones, but very seldom it created problem for us.
Yes, sir. As I said in my initial slide, only 2.3 to 7% of these cases, amongst where the spillage has occurred, they come to us back with complications. So most of the cases we just escape out.
In my practice, I always try to retrieve all the stones which can be taken out.
That definitely is the right process,
The
sir.
small particles we leave behind, and we give a higher antibiotic, put a drain, and take it out after 5 days, something like that.
And that's all we can do, sir. Yeah.
Thank you, sir. Can we move forward?